Hello, my name is Dr. Charles Weaver. I am a medical oncologist and the founder and publisher of Cancer Connect. I want to thank you for joining us today for a live chat with Dr. Boris Kuvshinoff and Dr. Renuka Iyer from Roswell Park Cancer Institute on treatment options for patients with liver cancer. This program is part of a continuing series of updates on new advances in the diagnosis, treatment, and management of cancer, its symptoms, and the side effects of treatment. We are delighted to be able to bring you this two-way dialogue so that you can interact directly with world-renowned experts here in our community. We are very excited to have Drs. Kuvshinoff and Iyer as today's expert. Dr. Kuvshinoff and Dr. Iyer are co-directors of the Liver and Pancreas Tumor Center at Roswell Park Cancer Institute. Both are recognized experts in pancreatic and liver cancers. Needless to say, we are thrilled to have them speaking for us today. Today's program takes place in two parts. To begin, we'll hear from Dr. Kuvshinoff and Dr. Iyer. During the program, you will have the opportunity to submit questions. Just type in your question in the space provided below on the screen. Then after the presentation, both doctors will answer as many questions as possible in the time allotted. We appreciate your interest and participation. After the program is over, we'll host this program on our on-demand section here in the community so that you can visit it again or share it with others who may benefit from its content. Thank you again for joining us, and I will now turn the presentation over to Dr. Kuvshinoff and Dr. Iyer.
Good evening. My name is Boris Kuvshinoff, and I am a co-director at the Liver and Pancreas Tumor Center here at Roswell Park Cancer Institute.
And I'm Renuka Iyer. I am also a co-director here at Roswell Park's Liver and Pancreas Tumor Center. And thank you very much, Cancer Connect, for setting up this educational live web chat on liver cancer. Let's start off by talking about primary cancers of the liver. Hepatocellular cancer, also called as hepatoma, is the commonest type of primary cancers of the liver. And it begins in the liver cells, the primary hepatocytes, as we call them. There is another kind of primary cancer of the liver, also called as cholangiocarcinoma, and that actually develops in the cells that line the bile ducts that reside within the liver. And together, both of these are classified as primary liver cancers, and it is estimated that about 28,000 new cases of liver and intrahepatic cholangiocarcinoma or bile duct cancer will be diagnosed this year, 2012. When patients hear that they have a cancer within their liver, it is important to make a distinction about whether this cancer originated within the liver or has spread to the liver, also known as a primary versus a secondary cancer or metastatic tumor to the liver. At the time that it is diagnosed, a biopsy is usually performed that would allow you to make that distinction. And tumors that originate, for example, in the colon or lung or many other sites within the GI tract can also present with tumors within the liver. The focus, however, of this presentation is the treatment of primary cancers of the liver. The treatments of these secondary tumors that spread to the liver can sometimes involve liver-directed therapy, but for the most part, the treatments discussed here are for cancers that originated in the liver. There are many risk factors for patients that present with these cancers, and cirrhosis of the liver, an inflammatory condition where there is scar tissue development, is a big risk factor for development of hepatocellular cancer. Chronic hepatitis from viral infection with hepatitis B or C are risk factors, as is alcohol use. Newer risk factors that have been identified that we believe are more common now than previously thought include something called NASH or non-alcoholic steatohepatitis and other conditions that can also cause inflammation and cirrhosis as listed here, hemochromatosis and primary biliary cirrhosis. The diagnosis of cancer of the liver is not an easy one. It has to do with knowing what the risk factors are, the underlying liver disease, and also doing an imaging study, a CAT scan or an MRI scan or an ultrasound scan that identifies the actual tumor. Also, a blood test called alpha-fetoprotein, if elevated above a certain cutoff, would suggest that the lesion in the liver is malignant in nature. Biopsies are not always necessary, but in some cases, if these other findings, the CAT scan and the alpha fetoprotein, are not enough to make the diagnosis, then the biopsies are done to make this diagnosis and confirm it.
So this is a picture of an actual liver tumor. This is a hepatocellular cancer, or hepatoma. And these hepatomas can present in various ways when we do the imaging. The picture to your left shows a very well-defined circular tumor that is brighter than the liver. It's a little bit more white, and that shows that it's enhancing, which is very characteristic. You'll see here on the actual specimen, this patient had removal of the right lobe of the liver. You'll see the nodular, knobby appearance of the liver. That's the cirrhosis. And then the tumor itself, which is a tannish, almost fish fleshy look to it, that's the actual tumor. And you see that it's well encapsulated and actually pushing the cirrhotic liver and blood vessels away. So we call this a pusher or a well encapsulated tumor. Now that's very different than what you're seeing on this CAT scan. What you're seeing here is a cut through the actual liver. The spleen is over here on the right side of the screen. And what you'll see here is a very diffuse tumor that's infiltrating or invading through and expanding the right side of the liver. And you'll see the tumor is actually growing into the portal vein here, and this is evidence of what we call vascular invasion, and that's a very important finding because that shows that this is a more aggressive tumor. Sorry about that. Here we go. Now, the other kind of tumor that Dr. Iyer talked about was a cholangiocarcinoma. Now, this tumor has a little bit different appearance. You'll notice on the slide in the upper left-hand corner in the picture, most of the tumor is dark. These tumors tend to be not as vascular. They tend to be more scar in appearance, very dark, as opposed to the primary liver cancer cells, which are brighter and enhance more. You'll notice here on the lower part of the lower left-hand side that here's a tumor in the middle part of the liver that's actually obstructing the bile duct. So this is a very central intrahepatic cholangiocarcinoma rising from the bile ducts. These tumors also can metastasize within the liver. So you can have a large primary tumor in the liver, and you'll notice on the right lower picture, you'll notice 3 spots there, and those are tumors that have metastasized within the liver itself. Now, taking care of liver cancer is a very complex problem. It takes a multidisciplinary team, and that consists of surgeons, such as myself, medical oncologists who specialize in liver tumors, such as Dr. Iyer, but the two of us work with a large team that includes radiation physicians, pathologists, radiologists, liver specialists who help us with the non-cancer part of the liver care, as well as dietitians, specialized nurses in oncology. And although we don't have a liver transplant center here in Buffalo, we do work closely with liver transplant centers in our region. Now, there's a number of factors that are going to dictate the decisions that we make and the sequence of diagnostic and treatment strategies. Both with cholangiocarcinomas and with primary hepatocellular cancers, the number, size, and locations of the tumors within the liver are very important. It's also very important how well your liver is working. How bad is the cirrhosis? How good is the function of your liver? Because if your liver has very poor function, we're not going to be able to do as aggressive treatments. For example, in a severely cirrhotic liver, we can't remove half or more of the liver because the remaining liver won't regenerate. As everyone, I'm sure, realizes, the liver has enormous regenerative capacity, but not when there's cirrhosis. The cirrhosis limits the ability for the liver to grow back. So that's just as important in the decisions we make are the characteristics of the tumor itself. It's also important to see if the tumor is spread outside the liver, because we generally will not recommend surgery if the tumor has spread to lymph nodes or the lung or other organs. The patient's overall health is very important. Age is one consideration, but a very healthy 80-year-old can undergo treatments, whereas maybe a 60-year-old that has a lot of medical problems may not be able to undergo an aggressive treatment. So we really look at the overall condition of the patients. So when we say multimodality, what we mean is different treatments. And the different treatments can vary in how aggressive they are, and they can vary in how intense they are. For example, surgery, such as removing part of the liver, doing a liver transplant, is a very big surgical procedure. Other surgical procedures that are much less intense and have much less stress on the patient would be something such as ablation, or destroying the tumor in the liver using microwave energy or radiofrequency energy, or the newest technology we have is electricity. Embolization is a treatment that delivers beads directly into the liver through the artery. So they do a catheterization, much like a catheterization looking for clogged arteries in the heart, but this would be going into the arteries that go into the liver and delivering either radioactive beads or drug-eluting beads, and Dr. Iyer will touch more upon this in a few minutes. Other treatments that we'll talk about are systemic therapy, where you give chemotherapy or oral therapy, and it gets to the liver through the bloodstream, and then we'll talk about some clinical trials. Surgery, resection really is removing part of the liver. So if the tumor is localized to one side or the other of the liver, we can remove it. If the liver is not, if it's not removable with enough liver function, then we would consider transplantation. Now, transplantation obviously is yet even more complicated in the sense that patients have to go on immunosuppression. There's also the issue of availability of transplant organs. There's over about 6,500 cases of liver transplant in the United States, but not all of them are for liver cancer. So there's a very strict criteria for who is eligible for a liver transplant. And we'll talk a little bit about some of those criteria, but there's a scoring system, and that scoring system determines if a patient would be eligible for a transplant. Obviously, the patient has to be in very good physical condition to undergo a transplant because of the extent of the surgery and the recovery involved. Now, hepatocellular cancer occurs throughout the world. There's over 500,000 cases worldwide. But this graph shows these are survival curves from different parts of the world, and you'll see that it's relatively similar whether you're in the eastern part of the world, in the western part of the world, in Europe, or in the United States. The 5-year survival with removal of the liver tumors runs about 40 to 50%, and that's gotten a little bit better with time, but still, even with surgery, a significant number of patients will recur, but we do cure patients with liver surgery. Now, the limitations I mentioned, if you have a lot of cirrhosis, if the tumors are multiple, if they're large, is a big problem for surgical resection. So the sobering fact here is that out of 100 patients that we see with liver cancer, only about 10% of them will ultimately be candidates for surgery or transplantation. Unfortunately, the nature of this disease is that it tends to present at a more advanced stage. Now, I mentioned about liver transplant because I get a lot of questions from patients about liver transplant, and the problem is it's not for every case. That's for certain. If there are certain criteria that they have, in other words, the tumors have to be less than 2 inches or 5 centimeters, or if there's multiple tumors, each of the tumors has to be less than 3 centimeters, which is a little more than an inch. So there are some limitations. So If there's very large tumors or multiple tumors, then patients would not be eligible for a liver transplant. And the reason that is because they just don't do as well. So if there's more tumors in the liver, patients would go through a liver transplant, but the results wouldn't be as good. So there are very strict selection criteria for transplant. Now we've been talking primarily about the liver tumors or hepatocellular cancer. We're going to talk a little bit about the cholangiocarcinomas or the bile duct tumors. Same situation holds. If they can be resected, then we recommend surgery. And you'll see here on the left graph that if it's a single tumor, the 5-year survival is about 50%. But with multiple tumors, the 5-year survival is not nearly as good. So in general, when patients have multiple tumors, we usually don't jump right to surgery. We typically will start with chemotherapy first. The tumor size also has an important impact. So if tumors are very large, I will tend to refer them to Dr. Iyer, who will give chemotherapy to shrink the tumor first before we jump into surgery. If the tumors are smaller, then we generally favor doing surgery up front.
In addition to these surgical options, or rather when they're not an option, then what happens? Patients come to us and ask, what else can be done for my tumor that seems to be localized to within the liver? And one of the ways this can be treated is with radiofrequency ablation, fancy term that describes burning the tumor essentially, using a long needle that is put inside the tumor, and the tip is heated up to destroy this cancer by sheer heat. Other options include injecting alcohol into the tumor, also done using a needle, can be done by an interventional radiologist as an outpatient procedure. Other options include microwave ablation and a newer technology also called as the nanoknife, where electrical current is used to ablate these tumors. This is a new technology, not available everywhere, and has recently become available here at Roswell.
Here's a picture of a radiofrequency ablation, and you'll see on the left side of the screen the actual tumor in the liver here on the top, and then there's the radiofrequency probe going into the tumor. And then on the right-hand side, the dark area there is the tumor after it has been ablated or heated, so that all the tumor has died, and that's what you're seeing on that scan. Here's another case of a 78-year-old patient who had hepatitis C with cirrhosis, and you see a tumor here that's white in the liver up on the upper left-hand portion of that picture. And then on the next slide, we'll see what it looks like after the radiofrequency ablation. So you see all the white area, the enhancement of the blood flow through the tumor has been removed, and this tumor is essentially dead. This is the CT scan from 3 months post-op.
In addition to this burning or radiofrequency ablation, another way of killing these tumors, especially if there are multiple tumors and you cannot actually reach every single one, is to embolize them. The principle behind this procedure is to basically take some sort of beads or particles that would be delivered right inside the blood vessels that are feeding the tumors and cut off the blood supply to the tumor. Transiently, of course, part of the liver also loses its blood supply, but thankfully the liver cells, the normal liver cells, have double blood supply, and they can survive this transient time of lack of blood flow. The different options include bland embolization, as the term implies, really just some sort of gel foam, oily particles are put inside. There isn't any chemotherapy per se. Chemoembolization, where actually doxorubicin, cisplatin, a number of different chemotherapies can be delivered. And all of this is achieved by going through a small catheter through the groin, just like when somebody gets a cardiac catheterization for their heart. Newer things available to improve on these outcomes have been things like drug-eluting beads. So these little particles are now releasing chemotherapy, radioembolization, with cirrospheres or theraspheres, small particles that now emit radiation. So the destruction of the tumor is not just by the physical presence of the beads, but also by the radiation emitted by them. Here's an example of what the angiogram done by the interventional radiologist looks like. And what you see here, where the arrow points, is this blush, almost like rouge. And that is really the blood supply of the tumor. This long catheter that you see in the corner, which is the long white structure, is used to then deliver the chemotherapy into the tumor. And after administering the chemotherapy and cutting off the blood supply, the embolization, the next picture that is taken where the dye was injected, as you can see, there is no tumor blush. All of those long blood vessels and blurry things are no longer seen. What about outcomes? How does this help patients? Randomized control studies have been done by a major big group in Europe. And what they've done is done this embolization procedure at baseline, then at 2 months, and then again at 6 months, because they believe the tumor is going to grow back new blood vessels and we should continue to get after it. And what they've seen is if you had control, which is basically no treatment, or this chemoembolization, outcomes are improved and survival is better than doing nothing at all. What about patients where these options are not an option? What if the disease has spread outside of the liver? Nexavar, also known as sorafenib, is an oral targeted therapy, the very first time that some drug has been shown to improve survival for patients with hepatocellular cancer and is FDA approved all over the world for this indication. However, unfortunately, survival for these patients still needs to improve further. And in order to do that and achieve this, several newer targeted therapies are being evaluated in major clinical studies, results of which are awaited for many of these drugs listed here. Let's shift gear for a moment and talk about advanced biliary cancers, intrahepatic cholangiocarcinomas. Unlike hepatocellular cancers, where not many chemotherapies are very effective, we have found gemcitabine and capecitabine, a combination of one IV and one oral chemotherapy, to be very well tolerated and effective in improving survival as well as the time that the tumor takes to progress. In addition to seeing these clinical outcomes, we've also found that it's so well tolerated that patients report their quality of life to be the same or better. And what that means is that the chemotherapy toxicities are not too much, they're tolerable, and so these outcomes are worth it for the patients. What you see here in these scans, where the arrow points is at a lymph node prior to treatment, and after chemotherapy, this lymph node has shrunk considerably. In addition, the same patient has a lesion in the liver that has also responded and gotten smaller post-therapy. These curves represent the responses in overall survival as well as the time it took to progress. Median survival was 14 months, and historically we expect these patients to have about half that time. Median time to progression was about 9 months. Probability of survival was about 60% at 1 year. For hepatocellular cancer patients currently, we have a clinical trial going on examining the role or the value of adding VT122 to sorafenib. The big challenge with treating patients with sorafenib with hepatocellular cancer is that they have a lot of problems maintaining their weight, their nutrition. And as you know, these are very important things for patients fighting cancer. So what we're trying to do in this study, which is going on throughout the country, is exploring other ways of improving their outcomes by trying to keep them on therapy and improve their quality of life on treatment. Thank you again for listening to us this evening, and we are ready to take any questions you might have. And thank you once again to Cancer Connect for arranging for this web chat.